In this lecture video, I will discuss about 2024 revision of MacDonald's Diagnostic Criteria for Multiple Sclerosis. Earlier, we have the 2017 MacDonald criteria and it was updated in 2024. And what are the different changes that have come in this diagnostic criteria to classify a particular patient to be having multiple sclerosis? There are some updates while we are diagnosing the patients to be multiple sclerosis with the clinical symptoms and signs. So, these diagnostic criteria mainly impacts the patient and doctor's dialogues, treatment decisions, clinical trials of the different drugs that are to be used in the management of multiple sclerosis and the prognosis of the multiple sclerosis. So, the general principle of multiple sclerosis diagnosis include the multiple sclerosis occurs throughout the world populations in all the geographical regions and race and ethnics. Multiple sclerosis is a diagnosis of exclusions, that is, there is no better explanation for the disease conditions. Brain and spinal cord MRI remains the most useful paraclinical test to aid the diagnosis of multiple sclerosis. An abnormal MRI showing the typical lesion is required to make the diagnosis of multiple sclerosis. Misdiagnosis and underdiagnosis may have a harmful effect for the patient because we may be able to initiate a new therapy for the patient by diagnosing the patients to be multiple sclerosis even though the patient was not the case of multiple sclerosis, and we may initiate a therapy for the treatment of it which can have a harmful effect on the patient. Multiple sclerosis diagnosis should be reassessed periodically with what is the improvement in it, whether there has been any relapse while we have initially diagnosed the patients, what are the new symptoms that has come in the patients, what are the new MRI changes that have come in the patients, that these patients should be reassessed periodically. And the statement applied to CIS, that is clinically isolated syndrome, may also be applied to the patients with previous relapse while we are diagnosing the patients to be multiple sclerosis. These are the different MRI findings in the patients with multiple sclerosis. Here we can see lesions at the paraventricular regions. These are the contrast enhancing lesions flare in the parietal regions. These are the lesions in the occipital, in the spinal cord can be evident. These are the infratentorial lesions in the brain stems which can be evident, and these are the lesions in the optic nerves, that is the optic neuritis. Here is there another lesions that can be seen, a perpendicular parallel lines running through the white matter hyperintensities. These are called as central vein signs. And here in SWI we can see that hypointense lesions which can be evident, and these are called as paramagnetic ring signs, which we will study about these in the upcoming slides. These are some of the changes that have been introduced in 2024 MacDonald's criteria. Thus, the proposed revisions in 2024 for the diagnosis of multiple sclerosis include that RIS, radiologically isolated syndrome in MS, is a specific situation. Optic nerves is the fifth topography which has been added in these proposed revisions. Dissemination in time is not longer needed while we are diagnosing the patients to be multiple sclerosis. there is a update in the dissemination in a space criteria. Kappa-free light chains has also been added as a tool to diagnosis of multiple sclerosis. There is same criteria for primary progressive multiple sclerosis and relapse multiple sclerosis diagnosis. There is need of paraclinical evidence to diagnose multiple sclerosis. More strict feature of confirming the diagnosis in an individual over the age of 50 with headaches, including the migraines or some vascular disorders. In these cases, a strict features has been added to diagnose the patients to be multiple sclerosis with these comorbidities and age over the 50 years. Addition of central vein sign and paramagnetic rim sign is an optional tool for the diagnosis in certain situations, and MOG IgG antibodies are used for confirming the diagnosis in children and adults. So, these are some of the proposed revision in 2024 McDonald's criteria. Thus, these RIS, that is radiologically isolated syndromes, is a specific situation that needs an biological diagnosis. These RIS, that is radiologically isolated syndrome, is identified by incidental discovery of CNS white matter T2 weighted hyperintense foci on MRI, as can be evident here, that demonstrate morphological and spatial characteristic highly typical of multiple sclerosis, but without any clinical symptomatology related to inflammatory demyelinations. That these patients have MRI lesions suggestive of multiple sclerosis, but this patient does not have the clinical symptomatologies suggestive of inflammatory demyelinating process. That is called as radiologically isolated syndrome. Thus, the patient of radiologically isolated syndromes can move up to clinically multiple sclerosis with a period up to 10 years of the follow-up. That is, 50% of the patients will come in the category of multiple sclerosis, and by 15 years, 72% of the patients will have the multiple sclerosis. Thus, this radiologically isolated syndrome is identified by incidental discovery of CNS white matter T2 weighted hyperintense foci on MRI, which is highly typical of multiple sclerosis without any clinical symptomatologies relevant to inflammatory demyelinations or findings on clinical examination. That these patients have the MRI features suggestive of multiple sclerosis, but there is no evidence to support the diagnosis of multiple sclerosis by other symptomatologies or on the basis of clinical examinations. So, in a patient with radiologically isolated syndrome, fulfillment of dissemination in a space and dissemination in time is sufficient to diagnose the multiple sclerosis. In a patient with radiologically isolated syndrome, dissemination in a space and presence of oligoclonal band is also sufficient to diagnose the patient with multiple sclerosis. And in the patients with RIAs, even the presence of dissemination in a space with 6 central vein signs is sufficient to diagnose the patient to be multiple sclerosis. That is, if the patient has MRI lesions suggestive of multiple sclerosis without clinical symptomatologies or without any clinical examinations, but it fulfills dissemination in a space and dissemination in time criteria, or have oligoclonal bands, or have 6 central vein signs, then these patients can be classified as multiple sclerosis. This is the update in the 2024 McDonald's Diagnostic Criteria. Then optic nerves as the fifth topography has been added in this proposed revision. Dissemination in time is no longer needed. There is update in dissemination in space criteria. Kappa free light chain is the tool for diagnosis, and there is same criteria for primary progressive MS and relapse multiple sclerosis. So it is more easily and widely applicable. Thus, we have said that optic nerves is the fifth topography which is added in this 2024 criteria, and thus optic nerve represents the first manifestation in MS in up to 25 to 35% of the clinically isolated syndrome. And the different rate of optic nerve involvement has been reported in established MS based on the sequences used, MS disease durations, that is ranging from 72 to 100% with the prior history of optic neuritis, and 8 to 72% in asymptomatic eyes. Then involvement of optic nerves can be assessed with MRI, VEP or OCT, ocular coherent topography, or visual evoked potentials. These optic nerve involvement can be assessed with these investigations. Considerable evidence supports that the minimal threshold of at least one lesions in at least two of the five topography after including the optic nerves is sufficient to classify the patients to be multiple sclerosis. Thus, at least one lesions in two of the five topographies. What are the five topographies? That is supratentorial, infratentorial, subcortical, a spinal cord, and the fifth topography is optic nerve. These are the fifth topography. Out of this fifth topography, any two topographies with even the one lesion is sufficient to classify the patients to be having multiple sclerosis. Thus, general recommendations regarding the visual symptoms in 2024 MacDonald's criteria is that optic nerves may serve as the fifth anatomical locations to demonstrate dissemination in space, apart from juxtacortical, supratentorial, infratentorial, a spinal cord, and the fifth one is the optic nerve. If no better explanation exists for optic nerve pathology, one or more typical short segments, intrinsic optic nerve lesions with no better explanations, including there is no prominent of chiasmal involvements, perineuritis or longitudinally extensive lesions identified on MRI may serve as evidence for optic nerve involvement to demonstrate dissemination in space. That is, the optic nerve involvement in multiple sclerosis are usually short segments with intrinsic optic nerve lesions without the involvement of chiasma or longitudinally extensive lesions. Thus, in BEP, there will be abnormal peak time using full field pattern reversals with visual evoked potential, with P100 peak times above the upper limits of the normal, with no better explanation, may serve as evidence for optic nerve involvement in dissemination in space. And as well as abnormal OCT may serve as evidence for optic nerve involvement for demonstrating dissemination in a space. Thus, to demonstrate the dissemination in a space for optic nerve involvement, either OCT findings, either VEP findings, or either MRI findings. These all can be included these all findings can be included for dissemination in a space for optic nerve involvement. Thus, CNS topography in multiple sclerosis diagnosis, that is dissemination in a space, is fulfilled by two of the five topographies, that is optic nerve involvement, juxtacortical, infratentorial, periventricular, spinal cord, supratentorial lesions, showing typical lesion regardless of whether these lesions are symptomatic to fulfill dissemination in a space. The fulfillment of dissemination in a space and time is sufficient to diagnose multiple sclerosis as stated in 2027, and the fulfillment of dissemination in a space plus oligoclonal bands or Kappa free light chain is sufficient to diagnose multiple sclerosis if no dissemination in time is needed, as updated in 2024 McDonald's criteria. In the patients with typical symptoms present with typical lesions in at least 5 topography is also sufficient to classify the patients to be having multiple sclerosis. In the patient with typical symptoms with typical lesions in 1 topography with 6 central vein signs or a 1 paramagnetic rim sign plus dissemination in time or CSF positive is sufficient to classify the patients to be multiple sclerosis. In a patient with progressive disease, even the 2 spinal cord lesion is enough to demonstrate dissemination in a space. So, to demonstrate dissemination in a space, even the dissemination in a space, even the 2 spinal cord lesion is sufficient, or 6 central vein signs, or 1 paramagnetic rim sign, or is sufficient to classify the patients to be fulfilling the dissemination in space. For dissemination in time, we have oligoclonal bands or Kappa free light chain or 6 central vein signs. These are all sufficient to classify the patients to be having multiple dissemination in time criteria being fulfilled. Thus, Kappa free light chain as a tool for diagnosis of multiple sclerosis. Besides oligoclonal bands, an excess of Kappa and lambda free light chains can be produced during chronic intrathecal inflammations, and these can be measured rapidly and quantitatively. Thus, Kappa free light chain in particular have a diagnostic property that seems similar to oligoclonal bands in multiple sclerosis. And here we can see that the Kappa free light chains have this Kappa free light chain have the sensitivity of 88%, whereas oligoclonal bands have sensitivity of 92%, and intrathecal IgG synthesis have sensitivity of 42%, whereas IgG index have sensitivity of 43%, and the specificity of Kappa free light chain is 38%. Oligoclonal bands have the specificity of 33%. Intrathecal IgG synthesis have 64% and IgG index have 64% of the specificity. Thus, this Kappa free light chain differentiate clinically isolated syndromes on MS from other neurological disorders, and the diagnostic property of Kappa free light chains are similar to those of oligoclonal bands being assessed with cohort. Kappa free light chains could represent a valid and easier rate independent alternative to oligoclonal band detections. An international panel of experts in CSF analysis recommends that intrathecal Kappa free light chains as an additional tool for diagnosis of multiple sclerosis besides oligoclonal bands after considering pro and cons of its techniques. So these Kappa-free light chains can also be used as diagnostic tool for diagnosis a patient of multiple sclerosis. Thus, the general principle being Kappa-free light chains is an appropriate paraclinical test for diagnosis of multiple sclerosis, and Kappa-free light chain are interchangeable with oligoclonal bands, and consequently it can substitute oligoclonal bands for diagnosis of multiple sclerosis. Proposed revision include need of paraclinical evidence to diagnose multiple sclerosis, more strict features for confirming diagnosis in individual over the age of 50 years with headache disorders including migraine or with vascular disorders, additional central vein science and paramagnetic ring science as an optional tool for diagnosis in certain situations, and mock IgG antibodies for confirming diagnosis in children and adults. So with these revisions, it has increased the specificity for diagnosing the patients with multiple sclerosis, will exclude the other causes that can mimic multiple sclerosis. In this revision, we have the ovoid-shaped Donson's finger. Ovoid-shaped Donson's finger, and these are thin hypointense lines or small dots. These are visualized in at least two perpendicular planes and appear as a thin line in at least one plane. These are a small apparent vein diameters of less than 2 mm and runs partially or entirely through the lesions and positions centrally in the lesions. These are some of the criteria for central vein science. What are the different criteria for central vein science? These are thin, hypointense lines or a small dot, visualized in at least two perpendicular plane and appears as a thin line in at least one plane. These are of a small diameter less than 2 mm and runs partially or entirely through the lesions and position centrally in the lesions. These are the central vein sign as can be evident in this MRI, which runs parallel and perpendicular through the hypointense lines and are of a small diameter less than 2 mm, runs partially or entirely through these lesions and usually positions centrally in the lesions. Thus this central vein science, demonstration of central vein sign in MRI can be used for diagnosis of multiple sclerosis, and the demonstration of central vein sign by MRI increases specificity in diagnosis of multiple sclerosis. The demonstration of central vein sign is not required for diagnosis of multiple sclerosis. Even the presence of it is not required for the diagnosis of multiple sclerosis, but it increases the specificity of the patients to exclude the other diagnosis. In a patient with typical symptoms and dissemination in a space, the presence of 6 central vein sign is sufficient to diagnose the patients to be having multiple sclerosis. In the patient with typical symptoms and typical lesions in one topography, the presence of 6 central vein signs plus dissemination in time or CSF positive is sufficient to diagnose the patient to be having multiple sclerosis. Thus, dissemination in central vein sign has been used as new revisions in the 2024 McDonald's criteria, and it increases the specificity of it. Dissemination in a space In a patient with typical symptoms, dissemination in a space, the presence of 6 central vein sign is sufficient to classify the patients to be having multiple sclerosis. In a patient with typical symptoms and typical lesion in one topography, 6 central vein signs and dissemination in time plus CSA positive for oligoclonal bands or Kappa free light chain is sufficient to diagnose the patient to be having multiple sclerosis. Then another revision that was added in 2024 is the paramagnetic rim sign. These paramagnetic rim sign, even one paramagnetic rim sign in SWI has high specificity, that is 99.7%, and low sensitivity, that is 24%, when distinguishing the MS or clinically isolated syndrome versus mimicries or healthy controls. Thus, here we can see that in multiple sclerosis, these are the paramagnetic rim signs as can be evident here. Thus, these paramagnetic rim signs, the demonstration of paramagnetic rim sign by MRI is used for diagnosis of multiple sclerosis, and dissemination of demonstration of paramagnetic rim sign by MRI increases the specificity of the diagnosis of multiple sclerosis. Demonstration of paramagnetic rim sign is not required for diagnosis of multiple sclerosis in a patient with typical symptoms and typical lesions in one topography. The presence of one or more paramagnetic rim sign plus dissemination in time plus CSF positive is sufficient to diagnose the patients to be having multiple sclerosis. Thus, to summarize with, if the patient have the symptoms and signs suggestive of multiple sclerosis, the initial workups that suggest the multiple sclerosis, including medical history, clinical examinations, imaging and lab tests, as well as the differentials. If MS diagnosis is not made, after these investigations, if MS diagnosis cannot be made, it should be ruled out because it is a diagnosis of exclusions, and mainly the history, examination, imaging should suspect the patient to be having multiple sclerosis. If these workups suggest the patients to be having multiple sclerosis, if the lesion is present in greater than 2 CNS topographies, or if the patient present with 12 months of progressive weakness and greater than 2 spinal cord lesions, then multiple sclerosis may be diagnosed if one or more of the following can be demonstrated. That is, if even the patient is positive for CSF oligoclonal bands, even the 6 central vein sign is present, even the patient fulfill the dissemination in time criteria, or even the lesions are apparent in the 4 of the 5th topography, then the patients can be classified as having multiple sclerosis. That is 2 lesions, greater than 2 lesions, or 12 months of the history of weakness or the symptomatologies, and 2 spinal cord lesions, plus any of the following, that is CNS, CSF, cerebrospinal fluid positive for oligoclonal bands or Kappa free light chain, or there is 6 central vein signs evident in MRI, or dissemination in time criteria is fulfilled, that is presence of enhancing or non-enhancing lesions on MRI, or the presence of new lesions on follow-up MRI, and the lesions are present in 4 of the 5th topography. If any of these are present, then patient is classified as having multiple sclerosis. Now, if a lesion is present in 1 CNS topography, including the patient have greater than 12 months of the progressive symptoms, then to classify the patients to be having multiple sclerosis, any one of the following features should be present. that is one CNS topography with 12 months of symptoms. Then CSF positive for oligoclonal bands with 6 central vein signs. CSF positive for oligoclonal bands with 1 paramagnetic rim sign. Dissemination in time criteria fulfilled with 6 central vein signs, or dissemination in time criteria fulfilled with 1 paramagnetic rim signs. If these are present, then the patients can be classified as having multiple sclerosis. That is 2 CNS topographies with 12 months of symptoms with 2 CNS spinal cord lesions. Any one of the following should be present, that is CSF positive for oligoclonal bands, central vein signs, 6 central vein signs, dissemination in time, or lesion are present in 4 of the 5th topographies, then the patient is classified as having multiple sclerosis. But if the patient has 1 CNS lesions in 1 CNS topography with 12 months of the symptoms, then any one of the following, that is in these cases CSFs along with other features are included. That is CSFs along with central vein signs, 6 central vein signs, CSF with 1 paramagnetic rim sign, CSF positivity, that is oligoclonal bands positive or Kappa pre-light chain positivity, or the patients with dissemination in time with 6 central vein signs or dissemination in time with 1 paramagnetic rim signs. Then these patients are classified as having multiple sclerosis. Then if the patient has incidental imaging finding suggestive of demyelinating diseases, then in these cases the initial workup like history, clinical examination, imaging and lab test, as well as the differentials which are included. After we have excluded the diagnosis, the multiple sclerosis diagnosis should only be considered after ruling out the better explanations. That is, we should exclude the other diagnosis, after which we can consider the patient to be having multiple sclerosis. All the mimickers should be excluded with history, examinations and imaging. After which, if the patient is classified as having multiple sclerosis, then the lesions are to be present in greater than 2 CNS topographies. And to classify the patients to be having multiple sclerosis, one or more of the following should be demonstrated. That is, CSF positive for oligoclonal bands or Kappa pre-light chain, there should be dissemination in, there should be 6 central vein signs, or there should be dissemination in time criteria to be fulfilled. Then only we can classify the patients to be having multiple sclerosis. With 2 CNS topographies, any one of the following should be present. That is oligoclonal bands, 6 central vein signs plus dissemination in time in an incidental findings of multiple sclerosis on imaging, that is RIS patient, radiologically isolated syndrome patients. Thus, 2024 revisions for McDonald's criteria in a patients who are being considered for diagnosis of multiple sclerosis present at the age of greater than 50 years with significant vascular risk factors like hypertension, smoking, diabetes, hyperlipidemia, or any vascular diseases or headache disorders, then additional features are recommended to diagnose the patient to be having multiple sclerosis. That is, a spinal cord lesions can serve as an additional features, positive CSFs can serve as an additional features, or central vein sign, 6 central vein signs can serve as an additional feature. So in a patient with greater than 50 years, with vascular risk factors, with headache disorders, to classify the patients to be having multiple sclerosis, a spinal cord lesions plus oligoclonal bands plus 6 central vein signs is sufficient to classify the patients to be having multiple sclerosis. pediatric multiple sclerosis, the pediatric and adult onset multiple sclerosis can be diagnosed using single diagnostic criteria framework. In patients with ADAM presenting with second clinical attack consistent with the typical multiple sclerosis attack or a new titulations in typical multiple sclerosis topography in greater than 90 years post-ADAM onset is required before MS diagnosis can be applied. That is 90 days post the ADAMS with a typical multiple sclerosis attack or with new titulations in multiple sclerosis topographies. That in children and adults less than 18 years, the presence of central vein sign in approx 50% of the T2 image is strongly suggestive of multiple sclerosis. The MOG IgG testing using cell-based assay is strongly recommended in children under the age of 12 years. And in a children above the age of 12 years, even incidental demyelinating events, MOG IgG testing using cell-based assay is required with the patient having typical presentation of multiple sclerosis. Thus, in a patient above the age of 12 years with incidental demyelinating events, MOG IgG testing should only be performed with the patient presenting with atypical presentations of multiple sclerosis. Thus, in pediatric multiple sclerosis, it should be considered with a multiple sclerosis lesions in T2 with a 90 days post ADAM onset with the children below the age of 18 years. Even the 6 central vein sign is sufficient to classify the patients to be having multiple sclerosis, and above the age of 12 years, MOG IgG testing should be recommended, but under the age of 12 years, MOG IgG testing should be recommended, and in a child above the age of 12 years, MOG IgG testing should be recommended in contrast with atypical presentations of multiple sclerosis, but not should be ordered in every patient suspected with multiple sclerosis. Thus, for a patient with primary progressive multiple sclerosis requires the evidence of clinical progressions over the 12 months. A single unified framework of diagnostic criteria should be used to diagnose relapsing and primary progressive multiple sclerosis. Thus, even a greater than 2 spinal cord lesion is evident for diagnosis of multiple sclerosis with the evidence for dissemination in a space. Thus, even a greater than 2 spinal cord lesions will fulfill dissemination in a space criteria to classify the patients to be having primary progressive multiple sclerosis. Now, there is some open questions for future revisions in this diagnostic criteria, that is demonstration in dissemination in time using BEP or OCT, refinement of the use of paramagnetic rim sign and central vein sign for solitary sclerosis and other atypical presentations. There should be some revisions in the criteria, and performance of criteria in diverse populations like Asians and other racial groups, and use of other biomarkers as a tool for diagnosis of multiple sclerosis. So these are some future revisions that should come while the next diagnostic criteria comes into action or when it will be revised. Thank you all for watching my lecture. Do subscribe to my channel for more and regular updates on interesting topics of the medical science.